All right, I would like to welcome back Dr. Thomas Patterson from Family Medicine. Yesterday, he gave us an excellent review on fever in well-appearing infants. Dr. Patterson is passionate about his work in trauma-informed care. His lecture this morning is entitled COVID, a New Adverse Childhood Experience. Dr. Patterson.
Great, thank you. Can everybody hear okay? So I sat in the back listening to the wrap up of the obesity lecture, and I thought how timely that I should be talking about ACEs, because the ACEs, the entire research base came from an obesity clinic, Dr. Folletti in Kaiser Permanente in California. He was seeing a lot of people fail out of his obesity clinic, and he decided he wanted to do exit interviews with everybody. And this one lady had been 460 pounds, and with a supplemented fasted diet over a year, she lost down to 140 pounds. I don't know how that happened, but it did happen. This young lady was in the nursing field in a rest home, a rehab center, and she was doing her exit interview, and it was a lot of questions about what did you weigh when you were born? What did you weigh when you started to walk? What did you weigh when you entered kindergarten? What did you weigh when you entered junior high? What did you weigh when you began having sex? And she said 40 pounds. And he paused and he realized he was supposed to ask, what age were you when you began having sex? And he had misstepped and asked her weight when she began having sex, which disclosed 40 pounds, which put her about 6 years of age. And she disclosed that she was being raped by her grandfather. So further investigation of that was that, why did you gain back to 430 after a year, having been successful getting down to 140? Well, go back to her position at a nursing rehab facility. At 460, she was not attractive to the residents. At 140, she was attractive to the residents. They made verbal and physical sexual encounters or attempts at encounters with her, and she did what she did when she was a child, and she ate herself into what she perceived as a non-worthy or a non-desirable form. So Dr. Folletti presented this at an obesity conference, and he was laughed off stage by all of the obesity experts in the world. And he went back to his table kind of moping, and Centers for Disease Control expert was there with him at the table and said, hey, I'll study this with you. So they looked at this population of people in Kaiser Permanente system, and they started finding that lots of people that failed out of the obesity clinic had a history of child sexual abuse, but also other traumas. So that started the whole thing. So incredibly timely that I should follow obesity. You all were talking about fixing something. I'm talking about preventing something. And as a pediatrician, that's all we do, hopefully someday, is prevent things. So all right. I need a teenager. I have no relevant financial disclosures. Going the wrong direction. That's why I wasn't working. So we'll talk about ACEs. I think I did already. We'll talk about toxic stress, which is really interesting. COVID impact on families. And then lastly, we'll look at how ACE fits into the definition of or how COVID fits into the definition of an ACE. So we've already talked about where this came from. This data confirmed that events in childhood increase the risk of certain poor physical, mental, and social outcomes later in life. And this was incredible what it found, but the adverse events came in 10 different domains. There were three domains, 10 different adverse events that they looked at, physical abuse, physical, sexual, emotional abuse, neglect. They looked at physical neglect, emotional neglect, and then they looked at family dysfunction. And family dysfunction included parents divorced or separated, violence against mother in the home, incarcerated parent, mental health diagnosis in a parent, or a drug substance use disorder in a parent. So I think when you think about this, we think about 1990s ACEs, and we think about, 40% of these people were college educated. They were mostly over age, or half of them were over age 60. So they're remembering back events from their childhood, and that related to health outcomes they had in a dose graded fashion. So everybody knows the pyramid. I love the addition of opportunities to intervene, and that's what we're doing in Idaho now. Is we're trying to promote opportunities to intervene. So you have your adverse childhood experience. If you don't have a loving, nurturing family that you go home to or you live with, that adverse childhood experience through hormonal and other measures ends up disrupting your neurodevelopment. The earlier you are in that disruption, the more significant it has in terms of future neurodevelopment. So you get your disrupted neurodevelopment. Again, if it's not buffered, you get social, emotional, and cognitive impairment. Again, if it's not buffered, you get the adoption of health risk behaviors. So that can be anything from drinking, smoking, drugs, promiscuity, eating, any number of different things that our patients do are often attempts to treat their childhood trauma. And we don't understand them as that. We treat them as independent disorders or diseases. I'm okay to get mental health disorders out of adverse childhood experiences. When they started talking to me about COPD and cancer and heart disease, I had to make a real big stretch and go back to figure out, how does our neurohormonal system work? And how does that impact my immune system, my neurologic system, my endocrine system? And it's all related. And I think, wow, we're created pretty incredibly well. Adoption of health risk behaviors gives you disease, more disability, social problems, unemployability, and you die earlier. If you have an ACE score of 6, you die 20 years sooner than someone with an ACE score under 6. If you happen to live in Nampa and you live on the north side, we have data that shows you die 9 years sooner than if you live on the south side of Nampa. So that's our area. If you look at Idaho, we have a larger percentage of children, almost 25% of children who've experienced an ACE score of 4, versus the national average is 21. We also have the highest, among the highest states in the nation, who there's no children with an ACE score of 1, or fewer children with an ACE score of 1. So we have a higher dose of trauma in Idaho. I think our rural nature is part of that. If you look at the death statistics, the only demographic that has not dropped in morbidity and mortality in the last 20, 30 years is females 35 to 39 in the rural setting. So I think that tells us that we're having a lot of trauma in Idaho, and some of it we can prevent now, all of it we can prevent initially. So if we go on, this is what I was getting at, suicide. I can see you had childhood trauma, you didn't buffer it, you adopted disordered lifestyle, you end up having a terminal end to a mental health disorder, suicide. But heart disease, respiratory disease, cancer, diabetes. If you think about stress causes a hormone called cortisol to bump. Cortisol is good for us when we're fighting for our health or running from a bear, but cortisol all the time is deleterious for us. And we know that cortisol on the brain stimulates all kinds of other neurohormonal cascades that can lead to heart disease, respiratory disease, diabetes, cancer. So 5 of the top 10, but there's many other diseases in the 40s and 50s that have a dose-graded relationship to adverse childhood experiences. So stress and toxic stress. So there's positive stress. That's like coming yesterday, talking to a bunch of smart people about a really complex guideline that's not binary like other guidelines, but I don't know, quadrinary. It was complicated. I was nervous talking to a lot of smart people about it. That was positive stress. I survived it. I got a compliment afterwards, so it made me think, okay, I didn't just babble for an hour. That's positive stress. I now know that next time I'm going to talk, I'm talking about constipation and autism on an echo project. That's easier than fever. Tolerable stress. This is what I thought COVID was going to be. I thought it was going to be this short-term to chronic, semi-chronic condition where all of our stress responses were activated for a long period of time, but it was limited. And then we're buffered by adults and our neurohormonal system comes back, our stress response system comes back to normal. And so that's what I thought COVID was at the beginning. We were talking about it'll peak in August, and by November, December, we'll be in good shape. And we know now that COVID is here for the long haul. This brings up toxic stress. So toxic stress are high levels of stressors that aren't buffered. And so your stress response system is continually stimulated. And that ends up having persistent changes in your physiology and become biologically embedded. We have mouse models where their fear center of the brain increases in mass with high doses of cortisol. We have PET scans and other scans in humans that have a high rate of trauma that showed their fear center is bigger as well. Their thinking and feeling center is smaller. So over time, when your stress response is continually activated, you change your structure of your brain as you're developing. And you can imagine we have all of our neurons by age 3 to 5, and then we start losing them. A cool little fact is after a birth of a child, if parents are in a good situation, both mom and dad's brains grow in the thinking and feeling part of the brain for 6 months. That's kind of what I'm talking about, the positive aspect of buffering ACEs. So toxic stress disrupts development if it's continuous. So the ACEs Aware is an incredible resource you can go to. They have kind of taken all of the science and cataloged it. They have everything that's happening anywhere in the nation. We're now on their map in Idaho, but they say high doses of cumulative adversity experienced during critical and vulnerable periods of early life development without the buffering protections of trusted nurturing caregivers and safe, stable environments can lead to long-term disruptions in brain development and immune, hormonal, and metabolic systems acting through genetic regulatory mechanisms. So this was just so perfect. I hate to read a slide, but that's so perfect. And that's what we're getting at is this unbuffered stress leads to permanent changes. So if we talk about the stress response system, we have the emotional brain, the amygdala, the fear center. We have the thinking and feeling center of the brain. The amygdala senses a danger and says, hey, everybody on board, we have a danger coming in. The thinking brain takes over, kind of assesses the situation and says, oh, this is just the pediatrician listening to your heart, baby. You're going to be okay. The thinking brain goes offline and the emotional brain comes back and says, fight or flight or even freeze. The thinking brain helps shut off the alarm system. So it's really pretty amazing if you think about kids that we see in the office. Some of them are hypervigilant. They're looking for an exit, right? I'm tethered, so I can't run. So that's got me anxious. But, we're someone that's had trauma that's stuck in, if you look at polyvagal theory of trauma, if they're stuck in that hypervigilant escape mode, they're looking for the exit. So that kid that's sitting on the bench up and down doesn't like you being between the door and him or her. That might be a kid that's in a traumatic response of, I'm gonna run. The kid that hides behind the exam table and doesn't come out, that might be the kid that's dissociating or freezing. And then we've all been kicked, spit at, and punched by kids that we see. Those kids might be fighting. They have been triggered by our response. Sometimes a trauma is a bad surgical episode with a child or a bad hospitalization episode with a child. It is totally common to see a child that's been in the hospital for 3 to 5 days come into the office and they want nothing to do with me, and I've known them all their life, right? So that is their stress response at work, and they're in a healthy fight mode or flight mode. They're not shut down, because who loves taking care of people with dissociative symptoms? Really tough group of people to take care of. But if you think about what's happened to them, you'll have a way better chance of taking care of them than what's gone wrong. If this emotional brain is always firing, it becomes chronic traumatic stress, it overwhelms our system, and we don't return to our baseline normal. And that's where we want to try to build positive childhood experiences to combat this. So the National Traumatic Stress Network, they have done an amazing job. It's a group of really impassioned people that have come together to talk about trauma and how it starts, how we prevent it, and how we respond to it. So this is a very long document, but I'll go through the 12 core concepts that kind of give us a basis for how we can think about our patients that come in. So traumatic experiences are inherently complex. Remember, their brain has developed in response to the stress response system for however old they are. So that's one variable. The parents may be great buffers, or they may not be so good at buffering because they had their own trauma. So remember, they're inherently complex. I'm surprised at how just asking about people's trauma allows you to make it a lot more simple. Caring by asking, Dr. Felitti says asking is a powerful form of doing, and I believe that's true. I've been in clinic situations where I've just said, I know you've had a lot of trauma. You don't have to tell me today, but sometime I want to hear because I care. And I find out everything from their first time of memory to their current time sitting in my office, every trauma that they've ever had, just with asking, I'd like to know your story because I care. And so then I can start understanding where mom's or dad's strengths are and where their weaknesses are and how I can capitalize on their strengths. So trauma occurs within a broad context: personal characteristics, life experience, current circumstances. It happens in a community. So if there is this broad context of a loving, social, happy community that supports families, that trauma is going to be buffered better. I have a family that just moved from Nampa to where the Walmart headquarters are in Georgia. She hasn't lived there yet, but her husband's lived there for about 6 months. And he said, it is so wonderful here. Everybody's so kind. The streets are clean. There are parks everywhere. There's resources for families everywhere. The libraries are huge. The museums are there. And they're moving to get to a place where there's a community that's better. The third one is traumatic events often generate secondary adversities, life stressors, and distressing reminders. So for instance, if a kid remembers being transported away from their parents in the car to go to foster care, that kid may be triggered every time they get in a car and have a tantrum every time they're going on a car ride, because in their mind, they're going to foster care again. And so just knowing where a kid tantrums can help you understand the questions to ask to get at where their trauma may have occurred. Children can exhibit a wide range of responses to trauma. This is what I talked about: the shutting down, the running, the fighting. How they respond has a lot to do with how it's buffered, how the trauma is buffered. And then kids that are constantly living in a dangerous situation, danger and safety are at the center of their being. That's all they think about all day long. So a kid who's thinking about safety all day long goes to school and does not learn a thing. They're afraid and they do not learn a thing. Traumatic experiences affect the family, broader caregiving system. You have a parent who's maladaptive. Sometimes the grandparents come in to be helpful. Sometimes the grandparents separate themselves because they can't stand the behavior of the parent. Sometimes they come in and take the child away from the parent and raise it themselves. So traumatic experiences live in a broader caregiving system. Protective and promotive factors can reduce the adverse impact of trauma. And then, I've nailed it multiple times. Trauma and post-trauma adversities can strongly influence neurodevelopment. The earlier the trauma is, the more impact it has. We just did an autism echo thing Thursday, and a child with autism had been doing very well, moved to Idaho 9 months later, started having irritability, aggressiveness, fighting, self-injurious and injury to other behavior. My trauma-informed brain said, well, is it possible that the move was that? And I thought, no, 9 months, that's pretty far. But then someone else reminded me that, well, when they moved to Idaho, it might have been kind of same for this autistic kid. But then when winter hit, that was different. So the sameness went away, and that's where the irritability came. So the whole concept was, how can we treat this kid medically? And me and one other person introduced, like, let's think about why this started. Now it's messed up in another way, complex, as I was talking about. Now he's in puberty. Puberty is one of those variables you can't control for. It's so variable in kids. So let's see, 10 is culture, massive impact. There are cultures that have different parenting beliefs than we do, and we can't judge them for it. We have to listen and understand and then advocate for safety for the kids. I found out in a learning collaborative I did for a year, we did parent focus groups with Head Start families. I found out from the Latinx community that they don't always tell the truth because they would rather take care of the trauma in their family circle. They don't trust that we can come into their family circle and be like family and help them take care of that trauma in their lives. I learned from our Native American population that they don't trust us because it's been harmful to their society to trust us in the past. So kind of understanding that cultural impact that will guide some of your interventions. And then, I think these kids and their parents are involved in the legal justice system oftentimes. There's ethical issues, judges and, penitentiary systems that have become trauma informed. There's less recidivism, there's less incarceration, there's less youth arrests, there's less youth substance use, there's less youth suicide. So communities that have become trauma informed see these huge benefits. And how long does it take? As little as 2 years to start seeing some of these impacts. And then we have to remember that taking care of these traumas can have an impact on us. One of the moms in our group said, I don't think my doctor was ready to handle what I had as a child. Therefore, I didn't tell him. And that made me super sad. Sorry, someone's calling me about a car warranty. So anyway, we have to think about how the experiencing it affects us. I can tell you when I started becoming trauma informed, I went home a mess a lot of times. I sometimes drove the longest way home so that when I got home, I was dad. So does anyone have questions so far? We're about to change gears.
Differences or maybe age, older child versus younger, making them more susceptible to the trauma event.
Yep. So the question is, ages, two children in the same family may have variable responses to trauma. And that's part of what I was talking about. It has to do with the age at which the trauma happened, the degree to their involvement. I have one family in particular where the child, 6 years old, started being raped by her father. The 3-year-old was watching, being groomed. The 11-year-old had not prevented it, though he knew something was wrong. The 11-year-old was suicidal at times. The 6-year-old, 9-year-old, when I found out, was suicidal at times. The 3-year-old had a grandma and a mom who, as soon as they found out, buffered it. The 3-year-old is doing, now 7, doing much better than the other two. And the other two are actually doing pretty well considering the gravity of the situation. So it's their neurodevelopmental age, it's how they respond to the buffering. I have 3 boys. Each one of them throughout their life have responded to different things I've done to build them up. And I treat each one of them very different because of that customized way I know that it builds them up to talk to them. So it has to do with the nature of the trauma, the age it happens, and the way that the child responds to the buffering. Moving on. So COVID impact on families. There's COVID disease. So this was the point at which I realized I had been completely wrong about how I was going to do this talk. I was going to talk about how don't let adversity make you misdiagnose someone with ADHD, anxiety, or depression. And then I found out actually adversity and COVID can go hand in hand. If we look at this graph, it's what we know. The young are getting disease, the middle-aged are getting disease, but the elderly are dying from COVID. I think the most important thing to remember about this slide is that some of our kids are being raised by their grandparents. And so when their grandparents die, it's losing their parent. So that's the important thing about this slide. As we go on, looking at child abuse, reports of child abuse during COVID went down. Woo-hoo, right? Our kids were at home. They weren't in school, they weren't in daycare. The number of eyes that were on them to detect abuse were oftentimes the victimizer and nobody else. So we started realizing that what we thought initially was families have drawn close together, and some did. Some did become stronger through COVID. But if you encounter the bear in the forest and you get away, that's great. But then you go home and the bear lives at your house. Now your cortisol is always high. And we remember cortisol makes your fear center bigger. And polyvagal theory tells us pick your choice. Do you want to freeze? Do you want to flight? Or do you want to fight? Right? So we didn't see as much, but we were wrong initially. At Johns Hopkins, they looked at COVID child abuse cases to total pediatric trauma cases coming in. It was 13% in the first year of COVID, where in the prior 2 years it had been 4% and 3%. And then in our own story in Boise, in the PICU, we had not had a child death from non-accidental trauma since 2017. We had 5 during COVID the first year. So child abuse is not going detected. Child abuse is not being treated early. Child abuse is now becoming more terminal because it's presenting at a later stage. So, if we look, I went up and down. So this was the one where I had to sit down, actually had to get up and walk away from making a PowerPoint when I started getting into the orphanhood story. I hadn't even thought about it really. I have one friend who lost her mother and father a day apart to COVID, and I take care of her kids. And I started thinking, oh my gosh, that's the story we're listening to here. So this is back in December, but US was number 4 in the world for the most number of orphan children by COVID deaths. What they did is they looked at the birth rate, they looked at the population, those getting COVID, those dying from COVID, and they were able to extrapolate how many children were impacted by the death of a caregiver, parent, grandparent, or other caregiver. So we got number 4. This is COVID orphanhood worldwide. I like to say orphanhood, like I like to say suffering homelessness rather than homeless. So I like to say orphanhood. Basically, it's a 2-to-1 ratio. Number of deaths from COVID gets you a parent or a caregiver that is not that dies from COVID and leaves those kids orphaned. So again, the traumatic impact of COVID-19 in families was studied by the National Child Traumatic Stress Network. Incredible resources here for families. Children and families are at increased risk for traumatic stress and loss. It's the neurodevelopmental age. They found that our Black, Native American, Latinx communities were impacted in a disproportionate way during COVID. This was largely because many of them were in frontline essential worker position. They had to go throw themselves in the face of COVID to keep their job, and many of them got sick, and the consequences of COVID were therefore experienced by these families more. Children and families involved in the juvenile justice system, child welfare system are impacted by this. In-person court cases stopped, in-person intake for CPS went down. They rallied, they came up with different systems, but they weren't the same as prior to COVID. And then think about transition age youth, your 18, you're away at college, COVID hits, and now you're isolated in your dorm room. You can't go out and experience all the things of college, which college is an amazing time for most kids. So lots of impact for families. We have to think about the impact COVID had on the child serving agencies. So mental health agencies, who can get a kid into a mental health worker quickly nowadays? Me neither. It's hard. They're overwhelmed. Telehealth has been problematic. I had one telehealth visit last week and their internet speed was so slow. I thought we were having dial-up internet speeds. I thought I could hear a modem in the background. And it's just, they're poor. They don't have the resources to have gigabyte internet like I do. And so it was terribly troubling for me, realizing this kid can't experience telehealth like other kids that have resources. Schools have had to adjust initially to closure, moving to online, but now to attacks on their existence, really. In Idaho, we're seeing that big time. Healthcare systems, healthcare workers are under strain. This is something we all have felt. And then child welfare and juvenile justice systems have strained. The number of people that walked away from child protection jobs was just massive because they had to go home to raise their own kids, or they just couldn't handle when they were figuring out that they were going to the ICU to do intake rather than going to the home to do intake. So financial impact, this has been incredibly real. If you think about 4 in 10 families experience some form of financial impact from COVID. Depleting their savings, trouble paying their bills, trouble affording or accessing medical care, lost jobs or wages. I would add finding, suitable housing. More than 1 in 3 families with children have challenges keeping their kids' educational activities up. Again, it comes down to, if you didn't have internet at home, you had to struggle to get it. And people came through with resources, but there was a delay of education because of it. So, you have an ACE score of 2, and then COVID comes along. COVID may be amplifying some of the ACEs. So as a dad, I had the opportunity to show my children how I responded to a pandemic. So that was the extra drive home, so that when I got home, I was dad. Families that have buffering, parents have said, this is tough, but we're going to come together. Those families have shown their children how you respond to a traumatic event like a pandemic. If you're barely surviving and a pandemic hits, your barely survivable status changes to can't survive. And now you're disrupting your whole family. And your kids are learning how you respond to a pandemic by watching mom fall apart or dad fall apart because they were barely holding on. And then, there's indirect social economic impacts, and these will go on for a long, long time. I think about all the people that quit good paying jobs with good benefits because they didn't want to get vaccinated. So now the breadwinner in the family is unemployed because they didn't want to get a vaccine. I saw that in my patient population quite a bit. And then, think about the pandemic is disproportionately impacting low income and ethnic populations. So we have to think they're at greater risk. And then, what can we do? This starts to sound like I'm a Debbie Downer guy, but tons of stuff good is going on. This was the whole basis of my talk originally, considering trauma and common diagnoses, consider that toxic stress may overlap. So even the expert can't decide whether it's trauma, whether it's depression, ADHD, what type of trauma is it, how it's been buffered. So it's easy to misattribute symptoms of trauma as overlap with some disease. We'll take ADHD as an example. If you think about your ADHD kid, there's lots of symptoms of ADHD. There's lots of symptoms of trauma. What you see in the overlap in the middle is, again, what we were talking about earlier, the hypervigilant kid, the kid that may be looking for the exit, the kid that can't think because they're in the fear center of their brain and they can't learn anything, kids that are, climbing, screaming, throwing fits. There's overlap between ADHD and trauma. And so it's important to consider trauma. I had one case pre-COVID where there was a change in ADHD. We had started an ADHD med. Kid responded great. Came in, things were falling apart. We appropriately increased the dose. I gave a talk to the residents about ACEs. And I had that resident with me in clinic the next day. They saw the kid and said, you know, I was thinking we should go up on the dose again, but I found out because I asked what was going on when ADHD stopped responding to the medicine. And this was a story where the older brother in this family had been victimized at school and then brought that home, didn't get it buffered very well and went to school and victimized another child. So then the 10-year-old got kicked off the basketball team because he was now a pedophile by association. The school treated the 10-year-old, the kids and some of the teachers, like the 10-year-old was a risk because the 12-year-old brother had been victimized and then responded as victims often do and become victimizers. So I thought, okay, let's go back to the original dose that we know works and get this kid into counseling. ADHD got better as we processed that, as we intervened in the school to say, this needs to change. These kids need to be treated as victims, not as victimizers. And so this kid improved on an original dose, but it was a resident asking a really important question. What changed about the time ADHD changed? Was there something big? And mom hadn't made the association. Parents and patients won't make the association between trauma and their disease. I'm hoping that we see that there is an association. So we can promote safety by building routines and rituals. We can teach children stress management, relaxation skills. We can talk about traumatic events in ways that enable children to master their own emotions and feelings, and how to resolve stressful events in their life. We can correct untrue statements, distorted ideas about what happened and why. And then we can enhance children's ability to regulate their own emotions, behaviors, and physiologic reactions. So this is what the menu looks like for starting to prevent this. And it seems overwhelming, but it's super easy. I teach kids in the office some breathing biofeedback things. I love the iChill app. I teach it to families. I teach it to older kids that can handle the iChill app. All the kids are on their phone anyway. So what's one more free app that has no in-app ads? And it's like having a counselor in your pocket. It's part of the community resilience model. And basically the iChill app, if you're melting down, you can push need help now. And a lady with the sweetest calming voice comes on and tells you what you need to do to like ground yourself, to breathe deeply, to do something to overcome that I can't do this anymore feeling. So I do this in moments in the office, in the hospital, super easy stuff. And I'm starting to do this. I'm having the power of positive. So we know that a kid that has the ability to talk to the family about their feelings has positive experience that buffer adversity. We know that kids that feel part of their family or have an adult who love them is helpful. We know that enjoyment in community activities, community rituals, those are helpful. Feelings of belonging in high school is a positive experience. So those kids have less adverse reaction to trauma. Feelings of being supported by your friends, that's important. Having, at least 2 adults in your life that are loving and nurturing, and then feeling safe and protected by an adult in your home. And so some of these communities that have become trauma-informed are trying to reunify families to get at least one person in the home that loves them, that gets this stuff. And so then that child will buffer all adversity there forward in a more healthy way. So I do a lot of promoting of self-care. I teach this to families in the nursery. AAP studied this. Parents who had to pivot during COVID to teach their kids in the home. 19% said, it was stressful. 31% said it was positive. There's a mix in between. I know the percentages don't add up. The slide didn't come across right, but there was 100% studied, but basically 31% said positive, 19% said negative, and there was a mix of, it was a little of both in between. the parents who said it was positive more often did self-care or had routine fun activities with their children. So I tell parents, see, self-care is important. You're a better parent, you're a better teacher if you're doing self-care. This study of a real world timely activity tells us this. So I love this article. So, challenges during COVID, we had to realize most US children have experienced disruptions in their family, their lives during the pandemic. Educational disruption has resulted in increased tensions. Kids are not passing exams, they're not passing classes with as high marks. It's disrupting the entire educational system. But hope during this pandemic, we know that despite all this, 60% of families say, yeah, we grew closer. I saw this with my own family. My two oldest kids lived at home during the start of the pandemic. It was so cool to have everybody at home. It was so cool. And then my two oldest moved out, but gosh, they can't go a lot of places, so they come home a lot. And it's so cool that our family is in that 60% that became, we grew closer during the pandemic. Parents and caretakers who take care of their own life stress will show their kids how to take care of stress better. So I tell moms and dads who think self-care is selfish, that self-care is not selfish. I got this from a dear friend who had a patient mom who had a developmentally delayed child who was complex and needed total care. And this mom knew that self-care was not selfish care. And I stole that from her. And I tell parents that. So when moms and dads are doing self-care, they're actually holding class for their kids on how you do self-care. And I say, if you were a smoker, you would worry your kid would grow up to be a smoker, right? But if you did self-care every day, right? If your kids grew up to be self-care participants, we'd have more people that were well-adjusted, healthy adults that could handle adversity and go, okay, that happened. What can we do to improve? And then, those who work with children and families listen carefully to elicit parents' own experiences. And you can try to figure out where they can become more close and help parents create more positive experiences. Give them suggestions like reading together as a family, having meals together as a family, stuff we've been doing forever. So I didn't reinvent the wheel to do some promoting of self-care. So I'm not going to read this, but the AAP basically said, during the pandemic, our children are growing and developing. We have an opportunity to blend bad experiences with good experiences, but we want them to have a memory of how their family grew closer in the end. Incredible statement from AAP. So ACEs are common. We know they happen in a unique biopsychosocial context. Toxic stress forms the neurobiologic framework that has us have a good response or a bad response to ACEs. We know that ACEs are preventable. We know that COVID fits as an ACE because of the toxic stress and the definition of an ACE. This was something children weren't prepared to deal with. That is how I break down ACEs, something that happens in a child's life that they're not prepared to deal with. And then we know that hope conquers ACEs. The Idaho Resilience Project has a tab for hope. You can go and write a note for an adult or a child on there, a message of hope, and we post it. It is the coolest thing. If you're feeling down and you need a message of hope, go to the Idaho Resilience Project page, look at the hope tab and read some of the things. You'll remember, oh yeah, this sucks, but I'm going to be okay. I've done way greater things in the past, overcome way greater things. So my last comment, and then I want questions. The number of children with an ACE score of 0 just went down with COVID. You have children and families who can add 1 to their list. If you were 3, you're now 4, and we consider 4 to be positive in most situations. So I think, considering COVID as an ACE is completely realistic. At first, I thought I had this uphill climb, but it seems really easy to say COVID's an ACE. And then I put in a bunch of references for you all. If I were to give you the reference that's the best, it would be ACEs Aware. I love the website. It has tons of resources for families. The Idaho Resilience Project has tons of resources. Part of the Idaho Resilience Project work is we have gotten multi-million-dollar grants to form in each health district in the state a kind of community resilience board and we have one in Nampa, and we have one in Eastern Idaho. The Nampa one is 2C Kids Succeed. I can't remember the one in Eastern Idaho, but we're developing those community resilience boards in all health districts in the state.
Thank you, Dr. Patterson.
Thank you. I love to talk about this. Thank you for the opportunity.
And Art, go ahead. Wow.
I would say for the children and families who figured this out and have made things better for their families during COVID. That's the real applause that we need, is the families that have figured it out.
For our first question from one of the online participants, has anyone considered whether the increase in child mortality seen during the pandemic was related to a turnover of SVU detectives tasked with protecting children? How can physician providers help protect children and families when the system tasked with protecting them is failing?
Yeah, so again, I think this is something that's not insurmountable. So this last several weeks, we have, as a community of resilience warriors, I don't know what you want to call us, we are advocate, passionate for building resilience in communities. We got HCR 029 passed through the floor of both the House and the Senate, and this requires all government agencies that touch a child or family or an adult who's experienced trauma as a child to become trauma informed. And the whole basis of that is when they show up to the judge asks, what happened to you, not what's wrong with you. When they show up to the OB, they get asked what happened to you, not what's wrong with you. When they go to school and the kid's failing, they think what happened to you, rather than what's wrong with you. The kid in the school that goes from 0 to 60 in a few moments, he lives at 40. So really, let's think about it for a moment. Going 40 to 60 is not all that impressive. The kid lives at 40. So it's easy to understand he's going to be at 60 in a moment because he's not starting where the rest of the kids who have buffering of their adversities. So we make a trauma-informed community. It boils down to that. Ohio became trauma-informed. Within 2 years, they saw a turnover rate of their child protection workers where it went below the national average, where previously it had been one of the highest turnover rates in the nation. Job satisfaction of child protection workers was one of the lowest in the nation. In 2 years, went to one of the highest in the nation for job satisfaction. And we are satisfied in your job, you don't want to leave it. And so that's what trauma-informed from the top down. I talk about it as a physician. This isn't going to be solved in our offices. It's not going to be solved in our hospitals. This is going to be solved across multi-sectors, government down to us in the clinic. Well, this is something I've been trying to get going, is screen for ACEs in the office. We as a group, I was St. Luke's medical director of children's quality at the time. We did collaborative across the state to include a screening of the 4-month-old parent. So at 4-month well child check, life is pretty good. You might be sleeping more. You've got breastfeeding or other feeding down pretty well. There's shots, but you've already had one set and the child survived them. So 4 months is a pretty happy time. And so we ask parents about their trauma at 4 months. I start at 2 months saying, I'm going to ask you this next time. Think about it. I have a cover sheet that says, this is why I'm asking this. The first response we got from all of our focus groups in the Head Starts across the state was, what are you doing with this information? They knew they were going to be incarcerated. Their children were going to be removed from the home if they answered truthfully on this. So they decided, I'm not going to answer that because I'm going to be incarcerated. So what we've found in research is doing a de-identified ACE screen is going to get you better or more information about score. I don't really care I don't care about the legal implications from a clinical point of view if mom had an ACE score of 6 as a child. It was many years ago. But I know that, say mom was abandoned by her parents, and now I'm telling her, well, at night, when your baby's starting to cry, we're 6-month-old, the baby's been sleeping through the night some. Let the baby cry for 5 minutes before you go in and save them. If I know mom's been abandoned, I don't even go there. It's not going to work. Every time a baby cries, the mom's fear center goes, I'm abandoning my baby. Oh crap, I'm doing it all over again. So yes, we should be screening. There's been huge resistance to screening because people think you're opening up this huge box of trouble. But I would say it's the way you do it. I'd like to know about your story because I care. We let our, patient populations, like if you walk into our Emerald Clinic and you're a refugee, you're welcome there. If you walk into our Friendship Clinic and you are LGBTQ, you're welcome there. We do not have, and I have thought about creating an image of a suitcase with trauma just vomiting out of it. We care about the trauma in your suitcase. But we don't tell anyone. If we're not asking, we tell them, I don't want to know about your trauma. And the one mom verified this. I don't think my doctor's prepared to hear about what happened to me. So a couple resources to help you. Trauma Proofing Your Kids by Levine. Incredible. It acknowledges trauma exists and we need to trauma-proof our kids from it. The Connected Child by Karen Purvis is an incredible book. I have no financial relationship to either of these books, but The Connected Child is Karen Purvis. She is a psychologist who worked with kids who, if you got into the mind of the darkest criminal, you could not fathom what happened to these kids. They were tortured in every area of their life you can imagine. She taught them how to feel loved and safe again, and then she wrote a book, How You Can Make Your Kids Feel Loved and Safe. So I caution parents that it was written for adoptive and foster family kids, but cross that out and say this was written for my family. I used one, I sadly found this when my kids were teenagers, and I used one thing out of it. You can say anything you want to say to me, just say it with respect. I said it calmly for about a week every time they were disrespectful, and then I didn't say it for about a month or so. And then my youngest son wanted to do something. I said, yeah, you can go do that as soon as you've done this. He didn't do that and he wanted to go. And I said, well, you can go as soon as you've done this. He blew up at me. And I said, you can say anything you want to say to me, just say it with respect. And he just blew up and finally got out, Dad, you're reading again, aren't you? So that was so awesome for me. And I felt some pain because I didn't have it when my kids were 2 and 3. And as a pediatrician, I experimented with everything I came up with. And my kids now as adults share with me, Dad, every time you did something new discipline-wise, we amped up our behavior because we thought it was funny to see how you responded that it wasn't working. So kids often will throw a behavior out there to see if that's how they use power. And my kids used it incredibly well, and unbeknownst to me until now they're adults and confess. Other questions?
Are absolutely wonderful. I feel a sense of hopelessness when I think about trying to do what you're asking us to do in a 20-minute office visit.
Yeah. So I will tell you that.
Can you repeat the question?
So I'm sorry. There's a sense of hopelessness when you think about what I've asked you all to do in a 10-minute office visit. RJ Gillespie in Oregon has published multiple studies on how this was implemented in his clinic. On average, it took him 5 extra minutes to do an ACE questionnaire, find a positive score, and do a warm handoff to a social worker, other community health worker, something that got that family to resources. So 5 extra minutes. I will tell you in my own practice, I have lots of late hours. Susan knows this because we share an office together. It's the coolest thing. But she knows I had long hours when I first started doing a trauma-informed approach. And I would tell you that I have one family where mom had 4 ER urgent care visits and 3 visits to our office in 7 days. I was in the office and the nurses came and said, Tom, the resident needs you in room, whatever. I'm running thinking airway, breathing, circulation. And as I'm running, I can hear a baby crying. I think, okay, not airway, breathing, circulation. It's gotta be a rash. So I go in and mom is crying hysterically, baby's crying hysterically. I try to calm the baby down. If you repackage the feet of a baby like they were in the womb, the baby sometimes goes. If you add their arms and make a shh noise, almost all of them go shh, unless they're hungry, or if they were breech. And if they were breech, you just put the feet up by the ears and they go. So I tried all that, it didn't work. So then I started doing some biofeedback breathing with mom, got her calmed down. The moment she stopped crying, the baby stopped crying. And I went, Mira, Mira. And look. And the baby stopped crying when mom started crying. So mom started crying again with tears of joy. So when I got her to quit, baby stopped. I have only seen her for well care since. So yes, up front, it's hard. Yes, up front, you need to do self-care because it's going to be an uphill climb. But on the other end of it, you have lots of well care. You have a better way to treat the ADD kid who had a victimization story in their family. You have a way better way of treating kids with mental health disorders by going back and helping mom. I have moms who I used to ask, what do you do for self-care? And I showered 2 days ago. I'm like, that's maintenance. Keep that up. That's good. What do you like to do that makes you feel like you're driving the steamroller rather than running in front of it, looking over your shoulder to see if you're going to get flattened? And then I build on that. What do you do for self-care? Like, what do you want to do? I have a mom who's read tons and tons and tons of books. She hadn't read a book since she had to in high school prior to that. Her response initially was, I showered 2 days ago. Now she does self-care all the time. Her kids were in for acute care visits all the time. I see them for well care now. It's so cool. Any other questions? So don't have hopelessness, have hope. Hope conquers ACEs. And we've got so many cool things going on in the state. The Idaho Resilience Project is, we've had $2.25 million of grants. We know we're getting more money and we're working on making resilient communities. And then I don't know what HCR 029 is going to do, but I have a really good sense that it's going to at least get our state officials thinking what happened to you rather than what's wrong with you. And that's where it all begins.
Thank you, Dr. Patterson.
Thank you.